Hello and welcome to part 3 of this 3-part lecture on principles of disease and epidemiology. So we were discussing transmission of disease and how it's spread, and we're going to continue with that discussion here as I pick up with part 3. So a vehicle, transmission by an inanimate reservoir like food, water, air, blood, etc. So there is a vehicle that is transmitting this. So it's an inanimate reservoir, and so that inanimate reservoir, it becomes the vehicle. So food can be a vehicle, water, whatever. So that's the inanimate reservoir that's transmitting it. And we call that a vehicle. Now a vector would be a living thing. This would be animals, arthropods, bugs. I mean, we typically, you could use this term for any animal, but typically we use it for arthropods, especially fleas, ticks, and mosquitoes. So this term can be used in a broader sense for any animal that's spreading a disease, but typically the term vector is used for those, for fleas, ticks, and mosquitoes. Mechanical, arthropod carries the pathogen on the feet or other body part. So this is, they are carrying it on them. They then land on your food, and then the food goes to your mouth. And so it's being carried mechanically on the body of that arthropod. With biological, the pathogen reproduces in the vector, and then the vector transmits the pathogen to the host. So through defecation, vomiting, or biting. So let's say the mosquito spreading malaria, for example. When the mosquito goes and puts its little needle proboscis into your skin, in order to do that, or while it does that, it secretes some of its saliva that has a little bit of an anesthetic in it in order to numb the skin so you don't actually feel it going into your skin. But when it does that, when it secretes some of its saliva, it secretes about a dozen plasmodium protozoa into your bloodstream as well. So that becomes a biological vector in that case. Some bugs, like the kissing bug, for example, and it's called that because it likes to bite your face, while it is feeding on your blood, it defecates at the same time. And what it defecates is, it's not like what you think with us. It's not like it puts a big turd on your face or something like that. It's going to be a liquid. And so then that liquid causes irritation and you scratch. And so the pathogens which were in what it quote pooped out, when you scratch it, it gets, you move it around, and eventually you're going to force them into the tiny little hole that the kissing bug put into your skin on your face, and then the pathogens enter that way. So there's a biological way of getting in. So like these pictures, I just show some examples where you have the mosquito, like I was saying, biting you, and the protozoa entering your bloodstream through its bite. There's mechanical, where it's carried on a person's hand. So at a restaurant, for example, what's their level of cleanliness? Are their workers clean? Are they washing their hands? Those types of things. And preventing the transmission from their hands to your sandwich. Or this fly. I mean, look at the little hairs on this fly. They're covered with all these hairs that enable them to have acrobatic flight, and they're sensory hairs as well. So there's a lot of surface area there for these flies to pick up pathogens, and then they leave, some disgusting mound of whatever that they were. Often the female flies lay their eggs and things like that. They pick up all those bacteria from rotting garbage or feces, and then they leave, land on your food, transmit the bacteria to your food. You just shoo the fly away, then you take a bite of your hamburger, and there you go, you just have ingested some bacteria. Now typically it's not a problem because the numbers are so small, but some of these pathogenic species don't need that. They don't need a huge number of them to get inside of you to cause disease. And so these are just different methods and means of transmitting these diseases. So we'll talk about hospital-acquired or nosocomial or hospital-acquired infections, as opposed to community-acquired infections. You probably have heard of CAIs, community-acquired infections. That means outside in the community. These are acquired within a hospital, and the hospital environment, as you know, is unique. There's a whole bunch of sick people in a pretty limited area, and so this becomes like a big incubator for diseases. So these are acquired as a result of a hospital stay. About 5 to 15% of all hospital patients do acquire them. Joseph Lister and Ignaz Semmelweis, he was Hungarian, they were pioneers in reducing them. So they showed ways in which we can reduce these hospital-acquired infections. Lister, by the application of phenol, which was the disinfectant that he used. It was a very powerful disinfectant. And Semmelweis, he just advocated hand washing with medical students, and I'll talk about that in a minute, working in hospitals. They were pioneers in reducing these hospital-acquired infections. Semmelweis was pretty much ignored with the protocol that he introduced. Lister, they paid a little more attention to him, but still, remember like I said in the last segment of this lecture, miasma. Miasma ruled. You breathed it in, and so you could use disinfectants forever, and it wouldn't stop you breathing in these pathogens. And it took a lot of work by Lister as well as Louis Pasteur and Robert Koch to end this ridiculous idea about how disease was transmitted. In the U.S., in the very developed country that we have, our great healthcare system, about 1 million of these hospital-acquired infections develop each year, and about 75,000 people die as a result of these HAIs. They've increased nearly 40% over the last 20 years. So what's going on with that? Why? One of the reasons is we have a larger aging population. We have a population that is living longer and longer and longer due to medications and drugs, keeping people alive longer. So as they age and get older, and we have new medical advances and techniques and drugs and medications available, people then need to go to the hospital because there is actually a procedure that they can have done to prolong their life. As a result of that, though, they're old, they have a compromised immune system, and they're going into a hospital with a whole bunch of other people with compromised immune systems and diseases and spreading it around, so that's one reason. There's a lot of people going to the hospitals. Another one is healthcare workers working for too long. Their shifts are extending. I know of one hospital in my area where the hospital did have, for the nurses, they had 3 shifts, 8 hours a shift, your typical 7 to 3, 3 to 11, 11 to 7, and that hospital was bought and taken over by a larger group, and they said, we don't need 3 8-hour shifts, we just need 2 12-hour shifts. So a whole bunch of nurses were dismissed, they were laid off or whatever you want to call it, and instead of having 3 8-hour shifts, they went to 2 12-hour shifts. These nurses were working too long. I mean, a 12-hour shift is a very long period of time to work in any job, let alone in the nursing field where you have to be on top of your game. You got to be attentive, knowing your patients, and when you're at that 9th, 10th, 11th, 12th hour of work, you're not thinking very clearly, you're tired, you want to go home, and so I think that is contributing to it as well. Again, and this reason goes with having more patients. There's just so many patients to deal with. A lot of healthcare workers just don't want to take the time to wash their hands in between every single patient that they see because there are so many patients that need to be looked at and treated. And so hand washing, I think, started to, we weren't washing our hands as often as we should have, perhaps. It wasn't being monitored as much. It wasn't being enforced as much. Also, another reason, I think, is antibiotic resistance. These bacteria are developing resistance against antibiotics. They're becoming more mutated species, and so they're developing infections within people that we have never seen before. And so these infections then can become more commonplace because we don't have antibiotics, for example, to treat them. And so more people develop these infections by just going into a hospital. At any one time in the United States, 1 out of every 25 hospitalized patients are affected by an HAI in some way. And that's a lot. There are a lot of hospitalized patients in the United States, and 1 out of every 25 are affected by them. Whether they develop them and recover, which is the case with most of them, but some of them, as you see, about 1 million develop each year, 75,000 die. Or they're affected by it. Not maybe they don't develop an infection, but in some way it has affected them negatively. So what's coming together here to make these hospital-acquired infections? You see that Venn diagram there. You have compromised hosts in a hospital. You have a hospital environment that is just a hotbed for microbes. And then you have a chain of transmission. They all come together to create nosocomials within hospital patients. According to the CDC, only 40% of healthcare workers wash their hands between patients. Now, I can tell you that has changed because of COVID. I guarantee it has now. I was just in the hospital this past week, and I was not the patient, but a family member was. And I noticed they are so vigilant about the alcohol foam. They have the dispensers everywhere. And every single time a nurse saw my family member, he or she disinfected. Every time. They disinfected before they put on gloves. They put the gloves on, they did the procedure, they threw the glove away, they then disinfected again. So in many cases they were doing the alcohol foam twice, just in like a 3-minute visit. So I can tell you for sure that has changed, and COVID has really wakened us up to this. So I'm interested to see, is one of the side effects of COVID, and this is kind of like a silver lining effect, will nosocomial infections be reduced as a result of COVID because of hospital workers constantly sanitizing their hands? I would think that, yes, they would have to reduce with all of this sanitizing that's going on, but a hospital is a very complex and complicated environment, so there are a number of variables and factors that could be affecting this. But I'm interested to see at the end of this year, I'm sure there's going to be studies on these hospital-acquired infections, and have they been reduced? We'll see. Compromised hosts, self-explanatory. People are in a hospital because something is wrong with them, so their resistance is low. Chain of transmission, direct contact from staff to patient, or from one patient to another, or indirect contact via fomites. Remember, they're the non-living things that people come into contact with, towels and cups and bedding and so forth, and the ventilation system. And have we considered the ventilation system? That is such an important thing to consider. HEPA filters are, in my opinion, essential in a hospital. You have to use these HEPA filters in all of the ductwork. And all of the diffusers that are blowing the air into a room, they have to have HEPA filters on them, because those are the ones that are catching these tiny little microbes. They can get down to like tenths of microns, and because of that they can trap the microbes, and then they don't get recirculated constantly in the ventilation system. So this is something that definitely needs to be considered within the hospital environment. This chart just shows the different kinds of hospital-acquired infections. The number one is urinary tract infection. These numbers they're not current, but I can tell you that UTIs year after year after year are the number one hospital-acquired infection. It may not be 34% in the year 2020, but it's going to be the number one nosocomial urinary tract. So these emerging infectious diseases, we talk about these in the first chapter, these diseases that are coming onto the scene and they're emerging. And I wanted to talk about it again in this chapter because this chapter addresses how they spread. So these are all new, increasing in incidence, or they show the potential to increase. So these are diseases that are being closely monitored by the CDC and the WHO. Now, COVID took us all by surprise. That one wasn't even being monitored because it wasn't on their radar. They were still thinking about the first round, SARS-CoV-1. SARS-CoV-2 comes out, and this was just a blindside slap to the face. This was not one that was even considered to be an emerging infectious disease. It just came out of the blue, from what we've been told, and it spread so rapidly, so rapidly. So anyway, some emerging infectious diseases that are being watched. Well, what are contributing factors to them? Evolution of new strains of them. So I guess you could kind of say that that would be the case with SARS-CoV-2. Is it an evolved strain of SARS-CoV-1? Looks like it could be. Widespread use of antibiotics and pesticides. We have these antibiotic-resistant strains now because everybody's just taking them like candy, and they're being prescribed when they shouldn't be globally. This is not just what we see in the United States. Remember, we just don't want to confine ourselves to this country. We need to look at this globally, and that's definitely the case. Antibiotics are being taken far too frequently. Changes in weather patterns. Climate change is definitely playing a role in these emerging infectious diseases. Modern transportation, of course, anybody flying anywhere in a short period of time. Maybe this with COVID will cut down on this. I mean, people just aren't flying nearly as much and they're not traveling as much. So not only does it cut down on the spread of COVID, but maybe it's cutting down on the spread of these other diseases as well. It would have to. I mean, this is a main contributing factor to emerging infectious diseases. Other contributing factors, natural disasters, tsunamis and hurricanes. I mean, they just destroy the infrastructure of cities, and so raw sewage comes up into the water supply. So obviously that's going to be a contributing factor. War, expanding human settlement. When countries are in war, they could care less about their healthcare system, and so disease becomes rampant. Nobody's getting treated because there's a war going on, and so people are not being cared for the way they should be. Animal control measures like increased Lyme disease due to rising deer populations resulting from the killing of deer predators. So you remove the predators of the deer, they really then what's going to happen to the deer population? It just explodes, and as a result of it, we have an increased Lyme disease because fewer predators, more deer ticks, more Lyme disease. So that's one of the reasons why we're seeing increased Lyme disease numbers. Public health failure. There was a diphtheria epidemic in the newly formed republics of the former Soviet Union because booster vaccinations were not given. And so whenever these republics were left on their own, they had no healthcare system because they were under the rule of the Soviet Union, and now they're on their own. They're their own entity, and they don't have any kind of, they're just trying to survive and become a newly formed republic, and in terms of healthcare, that takes the back seat. Epidemiology. So an epidemiologist is someone who studies where and when diseases occur, how they get transmitted in a population. There's a whole lot of math, there's a whole lot of graphs, and so they do a lot of research. Where did it show up? How did it spread? Through what part of the population? What factors contributed to the spread of it? Did race or ethnicity, did gender, anything? What all had to do with the spread of that disease? And so that's what epidemiologists look at. And they're not the microbiologists. They're not the ones who are researching the microbe and the pathogen and looking at the toxins it produces. The epidemiologists, they're just looking at how is it spread, and then how can we contain it and prevent the spread of it in the future or at the current time if it's an outbreak, if it's an epidemic or a pandemic. So right now during COVID, epidemiologists are working, it's a frenzy for them, trying to figure out how this disease spread, where it originated, and what is its chain of transmission. And then we learn from their research and their work about how to prevent it from happening again in the future. Some great epidemiological studies. John Snow, 1854, he mapped the occurrence of cholera in London. He made his famous 1854 map of London in the outbreak where he put an end to it by turning off the Broad Street pump in 1854. There's a great book about it. It's called The Ghost Map. It's such a good book. It's The Ghost Map, and it's about how John Snow led to the ceasing of this cholera outbreak in the slums of London. Great book. But he did all this. He mapped it. He looked at where it was going, and he traced it, and he interviewed people, and he went to their homes, and he knocked on their doors, and he talked to them, and he put himself at risk numerous times of getting cholera. But he was very, very careful in how he did his research and how he interacted with people, made sure that he knew it was being carried in the water, so he totally avoided the water altogether himself, but he wasn't sure what was being carried in the water. But he just did interview after interview, and he made a map of where the people were who had it. And then he finally came upon a couple of pieces of information that were his aha moment, and he was able to figure out that it was coming from this pump on Broad Street in London. Ignaz Semmelweis, I mentioned him earlier. He was a physician. He worked in a hospital in Hungary, or modern-day Hungary, and in 1846 to 1848. He was at a hospital. It was called the Lying in Wait Hospital. Strange name. But he noticed that the incidence of puerperal fever was really high among women who were delivering babies, or who were having their babies delivered by medical students. The women who were having their babies delivered by midwives, the rate of puerperal fever was like 0. But those who were having their babies delivered by medical students, the rate of puerperal fever was way higher, many, many times higher than those who were having their babies delivered by midwives. So what he noticed, that medical students were dissecting cadavers, which there was no formaldehyde or anything that was used to embalm cadavers and remove any, to reduce pathogen transmission. And so they were dissecting these recently deceased people with their bare hands. And then they were going to deliver babies. See, the doctors did not deliver babies then. That was beneath them. And so they had the medical students do the baby delivering. So imagine medical student Johnny, he's there dissecting a cadaver. He gets a tap on the shoulder and says, "Hey, Mary's ready to deliver a baby down in room 3. Why don't you go and do that?" So the medical student Johnny, he just wipes his hands off on his leather apron and goes and delivers the baby. And maybe he had to do some manipulation to get the baby out. Well, his hands they would have had blood on them. They would have had dead, decaying tissue on them. That all got transmitted into the woman's uterus, and then she developed puerperal fever and then died. So many, many orphan children during this time period. What Ignaz said was, hey, this is bad. We can't have the medical students doing this. Obviously, their dirty hands are causing this disease. So he wanted them to wash. Well, they didn't have, soap that we think of today. They didn't just squirt on some dial soap. They had the phenol. It was a very irritating substance, carbolic acid. But it worked, and it worked really well. But it irritated their skin, it irritated their respiratory passages. They complained about it to the administration of the hospital, and then the administration said, well, you don't need to do that anymore. It's really bothering you, so don't worry about it. So the medical students did not have to clean their hands off, and they went back to their regular practice, and then the rate of puerperal fever started to go back up again, and Ignaz left because he was so frustrated. So he was just ignored on that. And he had the stats to prove that what he enacted was working. Florence Nightingale, 1858, she showed that improved sanitation decreased the incidence of epidemic typhus among British troops. This was during the Napoleonic Wars, and she compared two groups, those that maintained cleanliness and those that did not. And she showed that those who had cleanliness and had good sanitation technique, that definitely decreased the incidence of typhus among the British soldiers. So they didn't understand the disease that was going on. John Snow didn't know there was bacteria that was causing cholera. Ignaz didn't know that there were bacteria that were being transmitted into the women. And Flo didn't know that typhus was being spread by the typhus bacterium either. None of them knew, but they knew that there were some practices that could be enacted that would stop the spread of the disease. So they didn't necessarily need to know the pathogen. All they knew was that there was something bad in the water or in the decaying tissue or in the filthy living environment. And so they realized that if we can just clean it, we'll stop the transmission of disease. Some investigative techniques, and the ones that I want my students to be aware of are the ones that are in green: descriptive, analytical, and experimental. So descriptive would be collection and analysis of data regarding the occurrence of a disease. And what I mean by retrospective is the disease has already occurred, and then we're looking back and we're seeing how the disease began and then how it disseminated within a population. So that's descriptive. Analytical would be comparing two groups, diseased and healthy, like Flo did, Florence Nightingale. She had a disease group and she had a healthy group, and she said, what's the difference between them? Why are the diseased men getting typhus? Why are they getting it so much more than this group over here? And she noticed that the group that was healthy, they were practicing better sanitation techniques than those who were in the diseased group. Experimental, study of a disease using controlled experiments like testing the effectiveness of a drug. The other two, case reporting and nationally notifiable diseases, this is just how these diseases are tallied. Where do we get the information from? And then we can have, like, like they use the term an epicenter of a disease. We can kind of narrow it down to where these epicenters are and where these the transmission seems to be happening more frequently than in other geographic locations. A nationally notifiable disease, so this is somebody comes in, like say with like crypto, for example. Somebody has cryptosporidiosis, that's a nationally notifiable disease, and someone from the Department of Health will contact you, and it has to be reported and then recorded by government agencies. It's just keeping track of it, tracing these diseases and seeing where they're coming from and how they're spreading. CDC, the Centers for Disease Control and Prevention, they are housed in Atlanta, Georgia. Collects and analyzes epidemiological information from the United States. Has a weekly report that's put out, Morbidity and Mortality Weekly Report. You can go to cdc.gov if you want to read that. So what is morbidity and mortality? Morbidity is the incidence of a specific notifiable disease, and mortality would be the number of deaths. So now we take those two terms and then we can get rates, and having these morbidity and mortality rates, that gives us a better idea of how contagious is this disease, for example. So a morbidity rate would be the number of people affected divided by the total population in a given time period. This is very much like the incidence. The mortality rate would be how many people are dying from the disease over the total population in a given time period. So diseases have all of these morbidity and mortality rates, and you can look them up. You can find out how many people were affected by the total population. So that would include everybody that got it. So you could figure out a morbidity rate for, say, the county that you live in for COVID. You could take the number of people that are affected in your county divided by the total population of people in your county, and that'll give you the morbidity rate. And the same with the mortality rate. How many people in your county have died from COVID divided by the total number of people in your particular county. And then that'll give you the mortality rate. And then you can do that statewide, nationwide, and globally as well. You can just keep expanding it out. And so these rates give us it's quantified data. It gives us an idea of what's going on with the spread of a disease. Okay, that's it. That ends my lecture on principles of disease and epidemiology. This was a 3-part lecture series. Hopefully it was a benefit to you, and my students, my college students, be prepared to know this information for a quiz and a test that will be coming up later, and I'll give you those dates. And as always, thank you for watching.